Awesome. And then
I know I'm going to do it in thing, but I can't find the thing. I'm trying to find it.
It's that bottom right button right by the scroller, down by the percentage left, right there. If you click back, you'll get to your home. Perfect. Thank you so much. All right, so we'll get started. It is 2 p.m. here, Eastern Time, 12 p.m. Mountain Standard Time, so we're going to go ahead and get started. Good morning, afternoon, or evening from wherever you're joining us today. My name is Ty Aller, and I'm a training coordinator for the MHDD NTC, and I'll be one of the moderators for today's webinar. You might also see my colleague Rachel Russo in the group. She'll be joining us to help moderate the chat, and you can shoot either myself or her questions as they go around technical issues. So the Mental Health and Developmental Disabilities National Training Center is proud to bring you our second webinar in collaborations to promote mental health supports across the USAID network, titled Breaking Down Silos, the START Model, with featured presenter Dr. Joan Beasley. We're excited to have her join us today, as she is a leading expert in the field of the mental health aspects of individuals with developmental disabilities, and I myself have already learned a great deal in my conversations with her. With that being said, it's my pleasure to give her an introduction. So she is currently a research professor and the director of the Center for START Services and the principal investigator on the National Research Consortium on MHDD. She holds a PhD in social policy from the Heller School at Brandeis University and a master's degree in community mental health counseling from Northeastern University. Dr. Beasley is author of the START program, first implemented in 1988, and has worked to promote the development of effective services for people with disabilities and their families for more than 35 years. START was cited as a model in the 2002 U.S. Surgeon General's report on the mental health disparities for persons with intellectual and developmental disabilities, and in 2016, START was identified as best practice by the National Academy of Sciences Institute of Medicine. START is researched and peer-reviewed as an evidence-based practice. And we're really excited to have her to present today. Before we jump in and turn over the time to her, I just want to go over a few logistical kind of operational procedures here. So we're going to be using the chat box today, and we ask each of you that as you have comments or questions to shoot them in there, and Rachel and I will kind of keep a tab on them and help them direct them to Dr. Beasley's attention. If you have any technical issues, please feel free to send me or Rachel a direct message, and we'll work with you to get that resolved. Everyone is currently muted, and we ask that you turn off your cameras for the duration of the presentation. At the end, we actually have scheduled about half an hour where all three of us will stay around and we can have a more open forum to kind of chat with Dr. Beasley. Currently, the webinar is not live captioned due to our live captioning services being overbooked at our university, and we apologize for that, but it is being recorded, and we will post it to YouTube with captions in the future. It'll also be on mhddcenter.org. I believe that kind of wraps up everything I have to say, so without further ado, I'll turn it over to Dr. Beasley.
Hi, welcome everyone, and it's my pleasure to be presenting today to this group, and I hope to encourage you all to follow your passion in this wonderful work in IDDMH, as I have over the last 40 years. It has been a very rewarding experience, and I'm very, very glad to have a center at a USAID at the Institute on Disability in New Hampshire. I think that has really made a difference in the work that we've been doing to try to break down silos. And a special shout out to my friends in Utah, the university, who are great partners of ours in this effort, and to the MHDD community as a whole. Well, that's interesting. Huh. Ty, my thing won't move.
So
oh, here, I'm going to try this. Okay.
There we go.
So this is me. Ty, my thing won't move. He's going to help me from Utah. So first I want to talk about kind of how this mission how our work has gotten started. Why do we talk about IDDMH? And part of that is because if you work in the disabilities field, in intellectual and developmental disabilities, part of the experience of the people that we work with and their families is that if you have an intellectual developmental disability, you are probably the most disenfranchised by the structure in our system of any person, including all other disabilities. People with IDD are considered the last and the least serviceable. For many years, they were not even considered to be capable of having mental health needs or emotional needs due to this false belief that having cognitive differences disallows you that human experience of emotional despair and mental illness. And as these structural and lifelong barriers continue in our society, it actually creates the opportunity for more mental health needs in the population and greater disparity as there are not organized training efforts in schools of higher education across the country. There is no consistency. The MHDD group that we are now a part of in this presentation, and the Center for Start Services and other organizations around the country are working hard to overcome this. But it has to be said that today, disparities among people with IDD and mental health needs continue, and that there are higher rates of mental health symptoms and challenging behavior compared to their typically developing peers. And again, some of this is attributable, in my opinion, to the way people are treated almost from birth. There are difficulties because they're misdiagnosed, underdiagnosed, undiagnosed, and even when detected, few evidence-based treatments exist. So if you are receiving mental health treatment and medication, you are less likely to have had that medication tested on people like you if you are not neurotypical. Most studies do not include people who are not neurotypical in the treatment of mental health conditions. So you might receive medication that's never been tested. And so really people suffer from the effects of being living experiments where physicians and prescribers are doing the best they can without strong evidence that's research-based and really relying upon anecdotal information and reports instead of true experimental design that should have been done to begin with. They are also less likely to have access to mental health care. They're more likely to be hospitalized, more likely to have police involvement, and have early mortality rates. And one of the things that we can't forget to mention is what happened in Utah just a week or two ago with regard to the 13-year-old child with autism who was having a mental health experience. His family called for help, and he was shot by the police in an altercation that occurred following that encounter. These are the kinds of things that happen all the time. And in the community system, people experience less understanding, more restriction, et cetera. And many services are guided by the bad reputations of people rather than a clear understanding. And effective treatment and supports require increased capacity in the system as a whole. So now that I've depressed you with all of this sort of background, this has been true throughout my career. And so one of the things that I've been working on since 1981 actually has been to figure out what we can do about this and how to promote positive systems change, including more humanistic interventions rather than just behavior management, which is one approach that is used, behavioral support. But there's a variety of other mental health supports that should be considered, and we would like to see them considered going forward. In 1988, I applied for grant and was awarded this grant in Massachusetts to develop the first START program with a team of my colleagues. Dr. Robert Sovner, who was a very important person in the field at the time, a psychiatrist, was my partner, as well as several others, including Herb Lovett, who was a psychologist who was very much into humanistic practices for people with IDD who had challenging behavior and mental health needs. So START's an evidence-based practice, and as Ty said in the introduction, we did some publications on our outcomes, and David Satcher, who was the Surgeon General at the time in 2002, featured START as one of the key programs to help overcome disparities in access to mental health care in the country. And then we received best practice acknowledgement by the National Academy of Sciences in 2016 as a result of our data collection and evidence-based methodology. The Center for START Services, which is something that I think you are more interested in learning about in this group, was developed 10 years ago in 2010 by me and my colleagues at the University of New Hampshire Institute on Disability, so that we could disseminate START practices in a more organized way, so that we could reach a wider audience and create a wider network. USEDs have really been developed in response to the need to have better services, supports, and understanding of the population. So this was a really good fit with the Institute on Disability and its mission to expand access and understanding of mental health aspects of IDD through the Center for START Services. Let's see if I can get this. Okay. So the START model is a community of practice that occurs all over the United States. We have the voice and input of service users and family members. This is very important in all aspects of START service. We ensure that the people who receive services have input as to how the services are employed. It doesn't mean that there is not expertise, but it means that the expertise is partnered with the experience so that people really are engaged and included in the process. And one of the things that we've learned in recent years, for example, there used to be a thought that people with IDD could not respond well to a clinical interview. They could not respond well to a clinical interview, and therefore you had to rely on informants to do a good mental health assessment. And really what we've learned over the years is it's not that they can't respond to the questions, it's about how you ask the questions and elicit the information. And the use of plain language and the use of other methods can help a person engage in their own treatment. So these are the kinds of things that we promote through the START model. And the Center for START Services houses a very substantial database. We have teams across the country that collect de-identified data, and through that data, we evaluate our practices, we look at best practices and to promote and change our work, and we do research and publication to promote a better understanding and capacity in working with this population. One of the things that we've learned from SIRS, I'll give you a couple of examples in our evaluation. Early on, even before SIRS with the original START program, we learned that outreach was essential in working with families, and that if you say to people, call us when you need us, people who are the most overwhelmed are less likely to call you until it's very late in the need, because they're trying to just sort of stay above water. And really the best efforts need to be made with us reaching out, reaching beyond the reach of others. Outreach meaning going to people when they need you rather than asking for them to come to you. So based on our studies, we modified our practices about 20 years ago, actually, at this point, and really go out to people rather than have people come to us. Another example is that if you are African American, you are more likely to be restrained physically and chemically in the emergency room than if you are not African American. This is what we have learned from our data. We have worked very hard and rigorously on inclusion and on Black Lives Matter and other practices to ensure that these disparities are both identified and addressed in the work that we do, identified and addressed. It really takes a lot of aggressive and heartfelt effort for a white person to listen and to learn from my colleagues in the African American community so that my practices improve. And we need to learn from the families we support and those people with intellectual and developmental disabilities who are subject to these racist practices. So it's very, very important that the data kind of helps us to get into the direction to really address this more carefully and to really show the evidence of what works and what doesn't. We have professional development standards that I'll be talking about a little later. And most recently in 2019, early 2019, we developed a national research consortium with private funding. This funding was donated funds from universities, for small grants, and also from Anthem to expand research partnerships toward humanistic approaches and strength-based approaches to emotional well-being. And so we are funding grants within our mission, which is to really promote humanistic methodology and not just deficit-based methodology. This is where we are in the United States. I'm not going to go into that. So a big thing that I researched when I first began this project and we began working toward what became the Center for Start Services was how to define effective service delivery. And there's 3 A's that I'm going to talk about very quickly: access, appropriateness, and accountability. Access speaks to the time and availability of those services, appropriateness, that the services actually match people's needs and that you provide the right tools to meet those needs, and accountability, that we're responsive, engaging, flexible, creative, inclusive. And one of the things that we know when we look at mental health services for people with IDD is that there's a lot of work to be done to ensure that these services are effective. So here's an example of access not being so good. Unfortunately, you have what we call no insurance, when your resources guide your access to the care that you need. And these could be as much reflective of the insurance that you get, but it can also reflect the location where you live in. There are states where in some locations you can have access to good care, and in some locations there is no access to good care. And really it's not about you or your needs, but it's about what is available, what is accessible in that location. And then there's appropriateness. And this is a big problem in our field, where the definition of what somebody's asking for doesn't always match the need that people need in order to make things better for them. And here's an example of Timmy is drowning, asking Lassie for help, and Lassie receives psychotherapy. I think that's Ty providing psychotherapy for Lassie about how sorry he feels that Timmy has drowned. And that is not appropriate. Lassie should have gotten help getting Timmy out of the water, Ty, just letting you know. All right. And then my favorite cartoon, which is our life experience, is accountability. And this is where we don't listen very well. And I am so glad that you have signed up for these leadership forums, because I think the biggest thing to learn as a leader is that there's 2 things you have to know. you have to really feel okay with not knowing everything. And that takes courage. And to quote Buckminster Fuller, to have the courage to be naive. You just have to have the courage to say, I don't have all the answers in any of the work that you're doing, but you're going to pursue getting them. It doesn't mean that you're giving up. It means you are open to the ideas of others. And the other thing that I see a lot of is meetings and forums where people are kind of competing for doing the speaking and the talking. And so what ends up happening is there's not really good engagement, especially cross-systems engagement. And people sit in the room, often segregated depending on what discipline they represent. And so here is a jurist talking to another jurist saying, I don't listen to the evidence. I like to make up my own mind. Now, how many times have we been in forums where that has occurred, or people make assumptions about people? And I think one of the things that we practice a lot at the Center for Start Services is paying attention to our own biases, our own assumptions that undermine our ability to be accountable in the measure of effectiveness that we're looking for. The other thing that we sort of another sort of conceptual underpinning. For those of you who don't know who Buckminster Fuller was, he was an architect, and he created the concept. He was a very close friend of Albert Einstein's, and I talk about Bucky so much, I call him Bucky, like he's a friend of mine. And he really created this concept called synergy. And synergy is a dynamic state in which combined action is favored over the difference of individual component actions. And in the 60s, when people were trying to be groovy, they talked about being synergistic. And the reason why synergy is so important is the behavior of whole systems is unpredicted by the behavior of its parts taken separately. Really, you have to merge in order for cooperative action to result in a difference or greater response than that of the individual action. So I'm going to show you a little demonstration of synergy right here. So we give these, we call them, I won't tell you what we call them, but anyway, we have these little magnets to demonstrate. So here you have two different systems. Let's assume one is mental health, the other is ID. And they're separate, and the little magnetic balls are the resources, and the longer pieces are the arms of the system, the knowledge base of the system. If you merge or synergize, you have not just two triangles, not just two systems, but three. It adds more depth, and you get extra resources. That's the concept of synergy. When we talk about breaking down silos, it isn't just because it's a nice idea. It's because when you break down silos and you work together, you have this synergistic response, which improves capacity as a whole. So when the USEDs in this country work together, it becomes synergistic. We collaborate, and together we develop more resources than if we function separately. And that's why having a national center like the MHDD Center is so important, and engaging with each other is so important, because synergy builds capacity and creates greater resources. So the Center for Start Services offers a lot of resources, as I said earlier. We have our database, and we also do professional learning communities, practice improvement groups, coaching, etc. The concept is that so what distinguishes us from the MHDD center that I'm now presenting in is we have a community of practice philosophy that all of the work that we do and all of the training and research we do is based upon. So the foundational practices are humanistic practices and inclusive practices. So whereas MHDD might have other practices as well. And I don't know what they are specifically. They, Ty and others can address that with you. We have a community of practice based on the START philosophy of systems linkage, of cultural and linguistic competency, and I'll go over all of those things a little later. So the idea is that we work together under the rubric of the START model, and all of what we do is based on that conceptual framework of biopsychosocial, humanistic, and positive approaches to supporting people with IDD and mental health needs. And so all of these things are available through the Center for START Services, which is a USED like the one that I'm presenting at now. So START coordinators are certified personnel. There are currently 325 certified START coordinators around the country. They're trained to do systems linkage modeling and also to participate in ongoing practice groups to improve their skills in the mental health aspects of IDD. So one of the things that we know in our work is that while we know more than we did yesterday, there's more to learn tomorrow. So we don't really know definitively what best practices are. We can only say that these are best practices now. And what we have to do is stay engaged so we can evolve and engage in best practices going into the future. And so we use lots of methods in which to do that. And it's really an acculturation into these training forums in order to create more independent and creative staff across the country, but also all linked to the National START Network, so that when we learn new things from the data or from the people who use services or from research and our research partners, we can then make sure that everyone gets the information and that we incorporate the new ideas and concepts into START practices so that they continue to evolve over time. So we do expect fidelity to the START model, and we provide training as the Center for START Services and technical support around the base methods that could require integrity. So for example, we are big sticklers on how we talk about people, how we talk to people, how we engage in dialogue, the methods that we use, and the need for research and evaluation. We have a group of prescribers from around the country, medical directors, who meet regularly to talk about best practice. We are on the final stages of the development of a best practice guide for prescribers. We believe that everything we do and all of the resources we develop need to be reviewed and revised every 2 years, which is it's a heavy lift, but very, very important so that we are as effective as we can be. And really this impacts our desired outcomes. So we do a lot of training in the START model, which is a crisis intervention program that is in 25 regions across the US. And these are the tools that are used. There are also therapeutic services, coaching, and all of them use multimodal, positive, strength-based approaches. So we promote through the Center for START Services what is considered the standard bearer of good health care through the World Health Organization, and that is a tertiary care approach to mental health care. And that means that all of our jobs is to build capacity and understanding of people who might have mental health vulnerabilities or systems that might create trauma and other difficulties, and improve the opportunity to change those odds, to create opportunities for the better through capacity building and shared understanding. This is why you're in this meeting. I mean, me talking to you today is not going to affect anything today, but what it might do is trigger some thoughts in you, hopefully, about what you might do a little bit differently tomorrow. And that's why dialogue, listening to each other, capacity building is so important. So the mission of CSS is really is that primary intervention capacity, but we also know that secondary intervention or specialization is needed. So we do promote and train a lot in professional development, from physicians, psychologists, and master's level clinicians to direct support staff and therapeutic coaches to develop that level of expertise to beat the odds when things have not gone well and capacity still needs to be built. And then at the bottom of the inverted triangle is facing the odds, the tertiary intervention. The START programs are on call 24 hours a day, 7 days a week, and across the country. And we do at CSS provide a lot of technical support and on-call assistance to those teams, especially during their training period. And the idea is to move from crisis intervention and crisis response, reactive strategies, to more proactive strategies, to an ordinary day. I mean, that's really what we're looking for, is just people just need to have ordinary lives. And really with primary intervention, it's really about breaking down barriers to things like housing, jobs, friendship, really promoting greater acceptance, rather than just, how do you deal with your anxiety and coping skills? I always say, coping with what? Coping with being treated badly is not just about you and your anxiety, it's about being treated badly. And so giving people joy in their lives is like a very important part of recovery for people who have mental health needs and for capacity in supporting individuals and families. So we also believe that a crisis is most often, a problem without the tools to address it. And we really do focus on crisis intervention, having a safety net, using tools, and we've developed tools and strategies. Really, some of the most seasoned tools that we use at CSS are our foundation of crisis intervention. So the START teams work with people who are considered high risk and have bad reputations. We reframe those reputations and reduce that risk. And really a lot of it is to reframe a crisis to a problem and then redefine how that problem requires tools, and then how to use those tools so that we can better promote wellness and well-being. And really, it's not about a pill or a plan. It's really about the person and their strength of character. And so again, we spend a lot of time using things like positive psychology and wellness promotion. Again, the World Health Organization defines wellness as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmary. This is extremely important. The mental health and IDD systems are very deficit focused, and even in person-centered thinking, there's a lot about services and support, and a lot of it is paid. And what really people need is a picture where they have more independence and less reliance on paid supports. And this only comes from the system as a whole paying attention to emotional, environmental, intellectual, physical, spiritual, social, and financial measures of well-being for each individual that we're talking about. And so we spend a lot of time talking about people who've been hospitalized, who've been picked up by the police, who've been put in restraint, who are on 4 medications. And we do a lot of investigation about how we got there and how to get out of that with people, but also how to promote well-being. So the resolution doesn't come from the intervention to prevent the person from going to the emergency room. The resolution comes from the person having power and joy in their life. So I have never come home, well, not come home, I'm always home. I don't come up from my basement office and my husband says, how was your day? And I don't say, great, I wasn't arrested and I didn't assault anybody all day. It's a little more about what has nurtured me and my sense of self that I would want to report. My joy comes from wellness practices, not from the treatment of illness. And that is a very important thing that we at CSS promote. So our approaches to best practice include cultural linguistic competency. And again, a lot of our early studies showed that people, especially people of color, especially African Americans, are disproportionately restricted. The response, the police are called more often than others. And we really decided that we needed to influence the communities in which we work by studying that further and coming up with approaches that were more proactive, more effective. I know you're going to be seeing To Our Good. To Our Good is our partner in this work, and we are very happy to have partnered with the Center for Cultural Linguistic Competency for many years. And that's another example of not being siloed as the Center for Start Services, but partnering with another USAID who has this expertise so that we can be stronger and we can build capacity. And we also use a lot of positive psychology practices, and I'll talk a little bit more about that in a few minutes. Positive psychology is the foundational mental health practice that we use for the treatment of mental health needs in people with IDD. It is part of our assessment work as well. We also look at primary medical conditions and other factors, and I'll talk about that again as well. So we teach through the Center for Start Services that inquiry and assessment are key. And as Albert Einstein said, if I had an hour to solve a problem, I would spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. A lot of mistakes made in the mental health care of people with IDD are the result of poor problem definition, poor understanding of the presenting problem, poor use of assessment. And so one of the things that we are paid to do as members of the USAID community is we are paid to think. And it is extremely important that we take that great honor and privilege seriously, and that we share that ability to think and expand that thoughtfulness with others that we work. So our guiding principles, again, are in front of us here. We are very much wellness-based. So again, the promotion of well-being is very important. We have a biopsychosocial approach, biomedical, psychological, and social. So we see that the entire human ecology is part of the definition of the problem and also helps us to define the solution. We are very much trauma-informed. We would say we actually just used a trauma screening tool in a recent study at START, and 100% of the people who used the tool had experienced trauma. Having IDD and mental health needs and having them identified, the identification of those needs is often surrounded by a lot of trauma. And so a trauma-informed approach is essential in the work that we do. We're very person and family centered, as I said earlier. We are working on research with the University of Florida and Georgetown on how to engage people, young adults with IDD, MH, in research with our research partners at the National Research Consortium, and making great efforts to identify some of the terrible things that have happened in the past and how to overcome them going forward so that we have better best practices and that we can include people who receive these treatments in the study of these treatments before they get the drugs and the interventions. Positive psychology and strength-based practices are key to what we do. And positive psychology is based on the work of Seligman. Dan Tomasulo, who is at Columbia University, is our mentor in positive psychology. And you can see that we have several partnerships. Tawara Good, as I said earlier, at Georgetown University is also a key partner with our center so that we can work together toward improving our cultural competency. The University of Florida, Jessica Kramer is an expert. She's an OT, and she is an expert in working and engaging people with lived experiences in all elements of service delivery, definition, and research. And we are very happy to be partnering with Jessica in looking at, and her team, in looking at things like plain language and making our work more accessible and inclusive, and not just having people with lived experiences in our meetings, but actually making sure that those meetings are accessible and that people can actively participate and contribute. I would say some of the most rewarding work that I've been involved with this year has been in working on the PCORI grant that I just mentioned earlier with Jessica and Tawara and people with lived experiences in our group to develop the training that we are developing right now. It has been really rewarding and very important work. Luke Kalb is at Kennedy Krieger Institute. He does a lot of the statistical analysis of our research. We felt it was very important to have independent research partners who could look at our data and evaluate it so that, I'm not just talking to myself. What's very strange is when you trust somebody with your data, you have to know that if you might prove that you're not as effective as you thought you were and be open to that. So what we decided when we first partnered with Johns Hopkins School of Public Health was that there's no wrong outcome. We'll either learn what we're doing is effective, or we'll learn what we're doing is not as effective as we thought, and we'll have indicators of how to make it better. So in either case, we're doing the right thing. And we also work with UNC School of Medicine, Dr. Roberto Blanco. We also work with Dartmouth Medical School and others. And we are working very hard on developing better clinical standards for prescribers, as I mentioned earlier. We got a grant from the WITH Foundation to develop a prescriber's guide, and we are in the final stages of that. And Dr. Blanco has been very helpful, as have others in this process. So I want to just talk a little bit about positive psychology and why we use it. And I'll start on the left with Seligman's definition of PERMA. PERMA is really the state of well-being we are all in pursuit of, and that we are all attempting to support people with IDDMH in. And PERMA stands for positive emotions, engagement, relationships, meaning, and accomplishment. And I translated that into our START strategies on the right, and some of the things that we do in the work that we do. And so we do something called strength spotting. We have mindfulness exercises, yoga, movement, etc. I'm not going to read all of this to you, but I offer this to you as an example, a demonstration of what we've been doing at our center, at our UCED, to kind of translate the mental health methodology and convert it to how you can implement it in the IDDMH world based on the START philosophy. And so you can actually, I highly recommend this, you can do this with all practices that you believe in. Take the practice itself and then figure out exactly what you would do to make sure that these things happen and work in your system. The other thing that I want to emphasize is that we take the diagnosis of a condition that people might have quite seriously. It's very, very important to not ignore. You know, people have difficulties that go beyond kindness to resolve. And it's very, very important that the kindness that we're talking about includes clear understanding of the issues that undermine people's mental wellness. And those things include biomedical issues, psychological issues, and social. The biggest thing that we've learned over the years with START is that medical conditions are often not really considered when somebody is having a challenge and they have intellectual and developmental disabilities. In fact, even if they just have mental health issues, they're often not considered. And those things being ignored really undermine best practice. So we really look at biomedical as very, very important, looking at the person's physical health, looking at what, you know, promoting their health, diet, exercise, good care, dentistry, etc., their psychological well-being, and also the ecology in which they live, their school, their work, their friends, their relationships. Notice it doesn't say their staff, their services, their support. Mental wellness is enhanced by services and supports, but it is not a foundation. Services and supports are not the foundation of mental wellness. Mental wellness comes from your natural self, both psychological and biological and social. So a little story, my mother lived in a nursing home for many years. She was in a wheelchair and non-ambulatory. She did not suffer from dementia, but she did suffer from a lot of medical and physical challenges. She required a Hoyer lift, and my dad could not support her, and we could not afford having care in the home. So my mother ended up in a nursing home, and she had people who took care of her. And so the one thing that I learned so much from her, but one of the things that she told me very clearly was when the aide came to see her every morning to help her, it reminded her that there was something wrong with her. Like every morning that she woke up and she was with paid support, she remembered she couldn't walk. Every time she saw me, and she would like criticize, what are you wearing in your hair? She remembered that she was a mother. So every time she met with a paid person, she remembered what was wrong with her. Every time she saw somebody who she loved, a family member, she remembered she was a family member. You can't ignore that reality and replace people's true life connections with paid people and think that one can replace the other. I think it's really, really important to keep that in mind. So how did we develop START to begin with? I'm a mental health practitioner by training. I have experience in IDD. Oh, I had at the time, really only by virtue of, well, I did do play therapy with young children with ASD early on in my training, so I had some experience in ASD, but really my life experience is my older sister has intellectual disability. She was somebody who was subjected to things that were not very pleasant. She was born in 1952. She was in the idiot and moron classroom. That's what it was called. There was a lot of stigma associated. My mother and father did not talk about my sister's differences. My sister was described as slow, but she was always my sister, and my family really loved her very much. My sister is married. She married a person she met in a sheltered workshop in Flushing, New York. They decided to get married against the wishes of many, probably including my parents. They have a son who's 30 years old, who's neurotypical, and he's actually a cameraman. He's a filmmaker. And it has been quite the little journey. And so as a mental health person, trained person, I speak one language. In the IDD world, we speak another. And when you look at the differences, they're quite distinct, and can often create a misunderstanding about the approaches. So in mental health language, we're talking about treatment. In IDD, we're talking about support. And really, in all worlds, you need support and treatment. So if you have IDD and cancer, it doesn't mean you're not going to get support around your treatment for your cancer. It's ridiculous that it's sort of segregated in that way. In mental health, you can't really get treatment that's effective without support. So, but the languages are different, and it's almost, it kind of silos you. And even when, in my early days with AUCD, even using the term mental health was problematic. People were avoidant of it. They thought saying that somebody had a mental illness was a label and discriminatory. There was a lot of misunderstanding about mental health language, because of the stigma associated with having a mental health condition. They actually threw out the mental health condition as being the problem, instead of, no, people can have mental health needs. People can be depressed and anxious. It's okay, but they shouldn't be stigmatized for it. So there's a lot of language barriers. And I told you the story about my sister because the language is about the stigma associated with the language. It's not really about the language itself. So my sister was in the idiot and moron classroom, though that language was just developed in the early 1960s in response to the label imbecile, which there was some stigma around. So they created idiot and moron, which then was stigmatized. So then they created mental retardation, which was then stigmatized. And so it goes. So it isn't really about the words you use. It's about the meaning behind the language and the stigmatization of the population. So there's also the person's perspective versus the provider's perspective. And again, once again, we should never assume that the person cannot share their perspective as a provider. What we have to do is find a way to make that accessible. And that's really what we're talking about. And we also have to look at what people and systems are telling us with their behavior, not what the individual is telling us with their behavior, but what everybody is telling us with each of their behaviors. So everyone is behaving in a certain way around a certain issue. It isn't just the identified person. And we need to listen to what families need and wish for, and we need to listen to their perspective, but we need to develop a common language and check our assumptions, and to develop competencies for improved communication and collaboration. So we saw all of this, and really it's a centerpiece of what we attempt to do on a daily basis at the center. And in doing all of this, as I said early on, we know that we're doing the best we can until we know better, but then when we know better, we have to do better. So it's this lifelong learning journey. You know, you can't just sort of say, well, I went to a class and I learned how to do this, and then now I'm good at it. Now I've got it. It's really not that simple. When you're working in the human service field, you really have to remember that humanity and shifts in humanity are continuous, evolving process, and that we can all always learn more. So our practice at CSS is to continue to look at, assess what we do, and look at the evidence. And so we are an evidence-informed practice. And this has really helped us in the context of our partnerships with other USEDs, our data collection methods, our analysis methods, et cetera. We often do in partnership with other USEDs from across the country. we really believe strongly that that the best research available is that consists of ongoing evaluation to inform interventions, that is the most important research. It isn't about identifying how many people have the problem as much as it is, well, what are the solutions? How can we help people in the context of those problems? And the other thing that we've learned, and I think is a very much the methods that we try to employ in our centers of excellence, is that collective intelligence helps us with our performance, that all levels in the hierarchy need the opportunity to speak. And when everyone gets a chance to talk, everyone does well. But if only one person or a small group speaks all the time, the collective intelligence declines. And that is very important as you study leadership. It's really not so much how much you say, it's how much you listen and help people to find a way to do something about what they're saying. It's not really about you having the sort of the lens. It's about how we share this vision together. I'm often asked, what is the method for developing a center like START? I mean, I started out with this model in 1988, and now we have a national model at the Institute on Disability in 2020, a very short amount of time. By the way, it takes time. I have to say that I never really intended to develop the center. It evolved over time through collective intelligence and collaboration. So I would say that the key to really taking advantage of being part of a USED is the wealth of opportunity, again, being paid to think, the wealth of opportunity that comes from collective intelligence cannot be underestimated in your mission to perform at your very best in the work that you do. So we have had very positive outcomes from the START model. Remember, the focus of the START model is crisis intervention. We've had lots of people who have, I think it's 25% of our population was in the hospital prior to coming to START, and about 70% had been in the emergency department frequently. And there's a dramatic, significant reduction in the use of those services, but most importantly, increased satisfaction with mental health and support services. So people were saying they were getting what they needed from the system of care, which was a very important measure of what we were looking at. There were three major elements to the Center for START Services, and I'm going to stop in a minute. They include the programs and practices that I've talked about, the research consortium, which is made up of many partners, including the University of Utah, and there's the professional development aspect of START. All incorporate our values of inclusive, strength-based approaches to improve capacity and promote PERMA. And so we certify START programs, and there's a process that occurs in order for that to happen. We certify START coordinators who are trained as experts in the field. They continue to stay involved with the network over time. We have the database, and I'm very excited about the work of the research consortium. We also, in our professional development work, have the online training series, which I think some of you have access to through the University of Utah. We also have the National Training Institute. It will be free again this year, and I'm sure MHDD will be helping us to promote it. This year, it's on mindfulness, and we'll be talking, that is our theme. Dr. Singh will be our keynote speaker. We'll share more about that. That's coming up in May. And we also have specialized training certificate programs for care coordinators in MHDD. That course is beginning next week. In integrated health in MHIDD for health providers, therapeutic coaching and direct support trainings. And we also have the mobile crisis responders course, which has been very popular and widely used throughout the country. One final thought, this is a leadership presentation, and I just wanted to mention that leaders rarely aim to be the leader. It's really about the focus on the mission, and through your passion for the work and your ability to collaborate, you model the way, and somehow things grow. It's completely by accident that CSS was developed. I don't think there was ever a plan for it, but I'm very proud of our team and our ability to continue to make a contribution. But really, it's not about our roles. It's about how we address our goals. And so I hope I leave you with that in hopes that me sharing my experience in this work has given you some food for thought going forward. Thank you.
Yeah, thank you very much, Dr. Beasley. And before we kind of open the floor up, we just like to make everyone aware that's attending right now that we have 3 more webinars in this leadership series, and the next one will be held on September 24th from 2 to 3 p.m. Eastern with the director of the National Center for Cultural Competence, Tawara Good. The title of that presentation is called Integrating Mental Health in USAID Core Functions, Cultural Considerations. The link to the registration will be in the follow-up email that we send with our survey and also on our website and social media. So now we have the opportunity to kind of actually engage with Joni for a little bit on some of this material with questions that you can either send in through chat, or if you want to send me a direct message, I can unmute you so you can ask the question. And to start, I'm actually going to ask a question that I've had recently. The question that I have, Joni, is one of the things I've noticed about all of your teams is that it's across the nation with people in various roles, and you find ways to really create a lot of synergy. And while I know your last piece was that it kind of happened serendipitously, it seems like you figured out kind of a recipe for success. And so I was curious on what are maybe some of the takeaways from your career on creating these teams in a USAID network.
Well, I think a couple of things. One is, I think one of the things that you have to be, or I have been over the years, and you know this, Ty, I'm very available. So you have to be available and willing to engage with people with no necessary outcome except connection. Like connection has to be the outcome. So you don't worry about whether or not you're going to get something immediate from it. The dialogue itself is a rich reward. So in my work, in my discussions with you, that would like really demonstrate that, Ty, right? Like we met in several forums, we've had several discussions. You know I'm going to maneuver something out of you. I'm very manipulative, right? I've invited you to be part of a research study because if we share this passion for the work, then why not engage in dialogue about how to work together? So it comes from that. And what happens is it's very contagious. So as you said, Ty, my entire team is like that. Our entire team does the same thing I do because there's such a reward in positive engagement that once you get into it, it's just it's just terrific. So I think the secret sauce is believing in what you do and being open to new people and new ideas.
Awesome. Thank you. Yeah, I do feel like that from each of your team members that I've worked with. There's this question here in the chat from Ashley Greenwald. She asks, could you send more information about the online trainings and training institutes for START? And maybe, Joni, you can even speak to how do people access those currently and how to get on your email list.
So our link for the Center for START Services is available on the MHDD website under resources. So the Center for START Services is listed there, and you can you can connect onto the website, and that will get you there. The other thing is that Ty, if people would like, and they can let you know, the participants in this training, we can include them in email notification about resources that are available. So how could we do that? Could we ask, there's 32 participants. Could they let you know if they want to be on our, if they want to be contacted by us with information? How would you like to do that?
Yeah, I can actually do that in two ways to kind of get a double dip. As we send out a survey to everyone, and in that survey, we'll list a question in the survey saying, if you would like to be added to the list of Centers for Start Services, we can ask for their email. We will also include in that original email a link directly to your guys' resources and programs, because I've actually taken some of the trainings and think they're very useful.
Thank you, wonderful.
So now we'll turn it over to the group to see if there are any questions. And if you want to engage, we'll stay on for as long as people want to stay around, if that's okay. We have it scheduled till 1:30. So we'll kind of monitor the chat here. And if you want to be unmuted, I still have it where I've got the control here for a second. But just shoot me a message and we can unmute you and kind of engage more on this. There's another question here from Kelly Clark that says, I'd love to find out more about the certification programs that you guys offer. Joni, can you just speak to those a little bit?
Yes, so we certify, there's something called STAR coordination certification, and that is a formal training. It's actually very comprehensive. It's also an apprenticeship, so you have to be able to practice START methods in your location in order to be certified as a START coordinator. We also provide certificates. We have certificates in the mental health aspects of IDD for care coordinators and case managers. And that is a course that you can take. And then there's a test at the end. There's a pre and post test. And you work with a teaching assistant and you get a certificate of completion for that. And there's also the mobile crisis team course, which has similar methods. You do have to take an exam at the end, but if you pay attention in the class, you'll be fine. The biggest certification is as a START coordinator, and depending on what state you're in, we can talk about how you might be able to get access to that. You have to have a START program in your network, in your location, in order to be certified as a START coordinator.
So if people were interested in looking into that, what would be the first step? Would they contact you, or would they contact someone on your team?
You can contact me, and we can talk about where you are and what you're interested in, and we can meet and have a discussion about how to get there. Often in states where there are no START programs, we meet with stakeholders and actually do a systems analysis of what is in the state, look at the resources that are available, and look at the needs in that state, and then work and if the state allows, we look at claims data to actually look at what is being spent on crisis reaction instead of proactive services to show the savings that could potentially happen with START coordination.
Awesome. So there was another comment here from Kelly Clark that says, I'm a clinician in a program in Massachusetts that provides shared living, and I'm actually a clinical social worker and not a behavioral specialist. And I've been working hard to practice more humanistic approaches in my agency. This is such a great fit, and so glad I attended, and look forward to finding out more.
Kelly, we have a team in New Hampshire that you can link with. And I live in Brookline. So Kelly, it's Kelly, my sister. Just reach out to me. The original START program is in Massachusetts, but it's a little funky, which you live in Massachusetts. But we'll talk offline. But yeah, please get in touch with me. I'm happy to help. Sounds great. Oh, and Kelly, you recognize that we're a social work model. Thank you for reminding me. We are a social work model.
So there's another question here. It says, is there a listing that notes who are START providers?
Yes, it's on the website. So if you go to the Center for Start Services is it com or org, Ty? I don't know.
I'm gonna have to look here. You keep talking and I'll look it up.
It's on, it's, yep. And yep.
It's just for everyone. I'll put it here in the chat too, but it's centerforstartservices.org. And then there's another question here from Diane that says, what is the cost associated with the system work that you just described?
It depends on the size of the system. So California is like a country. So we, I don't know if people work in California. We work in California now. It's a lot more expensive to do this work in California than Iowa. We are also in Iowa. So it depends. And what you can do is reach out to us. So one thing that, and Ty knows this, I have talked to him and Matt about this. We are longing to work with other USEDs in the expansion of START so that we are not, like, I don't want to be like the queen. I want to I want to work with others. I'm big on collaboration, and especially we want to spread the understanding of the model and the distribution of the model and work with other USEDs in this effort. So just to let you know that. But if you have questions about cost, just email me and we can meet. The other thing that is you should know, a little thing if you're trying to get people interested. 1 year of START services is equal to 1 week in a psychiatric hospital in terms of cost. Interesting, huh?
It's pretty interesting. A lot of your guys' data too is real fun to look at. And I think there's a lot more to be said about the START program than we necessarily have time for too. Let's see, there's a couple more questions. So can the information on the certification programs be emailed out to us? Yes, I'm happy to provide that to individuals. Right now, I don't know if everyone else wants it. So if there are more people than Leanne here that would like the information, please let us know. Otherwise, I'll just have Rachel write your name down and we'll pull your email from the list to send it out to you specifically. Then we have some comments here, Joni, that says, it would be great to have this model in Utah, from Julia Pierce.
Oh, Julia is here. Thank you, my sister. I agree. Actually, we had these conversations with Utah, and maybe if the Utah USED wanted to take a lead, Julia, you can influence them and Ty, and then we could collaborate. Right, Ty?
You know, it's never a meeting with Joni if we don't find a way to try to do some more work.
So one of the things, if you work in a USED, you know that no matter how much work you have, you never get a raise. So it's not about like money. It's about the cause. So I'm all for it, Ty. Let's do it.
You know, I was going to tell Julia, I was like, you're going to have to reach out to Matt to put on some more pressure for him. We've got Liz Diamond who says, I'm at USU and would love to bring it here too. And I think I'll throw out the subtle correction where actually, when she was mentioning University of Utah, she was meaning Utah State University. So she's
That's what I meant.
with
Yeah.
USU a lot, Liz. So that's exciting. Any other questions from the group or any other information that would be helpful?
So one thing I just want to say is that while I'm really excited about your response to START, I really, really want to encourage you all to follow your passion and find your, what it might be START, which is great, welcome aboard. But I think the message that Ty wanted me to make sure to share with all of you is that there's so much reward in finding your passion and in partnering with others. And there's so much opportunity that we all have to do that. And don't overlook that. I mean, this is a very important time. We are in a very strange time. And if there's any time for us to really work together to overcome obstacles, it's now. And, I welcome you to join us, but I also want you to know I will join you if there's anything that I can do to support you. And I really appreciate this opportunity. So thank you, Ty, and thank you, everyone.
No, thank you, Joni. And I think you really do back up what you say. Some people just say the vision, but you really do live it. So I appreciate that. Let's see, there's another comment from Kelly. It says, "This was so wonderful. Thank you. I've been following this passion for many years. Great to see the shared vision." Let's see, any other comments? No, it doesn't look like it. Yeah, well, I think we'll wrap up a little bit and just say thank you again, Joni, for your time today. We really
Thank you.
appreciated it. And we hope that everyone that's joining can see how things are starting to build. You know, we had Dr. Whitwer last 2 weeks ago that talked to us about more of the current status of research on clinical interventions for this population. And now Joni's actually talked about, you know, how programs and systems-based programs can actually work with states to try to facilitate better mental health and well-being. And next week, or in 2 weeks with Tawara, we're going to be talking about how to incorporate cultural adaptations into that. And the hope is through all this is it starts to give you information about how to actually incorporate what we're already doing in USEDS to address mental health needs across the United States. And I think that's a shared vision that Joni has too with the START program, and she's doing it in a specific realm. So there's plenty of space in this field for everyone. And I think if we work together collaboratively, kind of like Joni's mentioned, it seems to get a lot more done. So thank you again. And if there are no other questions, we'll log off here. And Julia's saying it's always great to hear from you. Have a great day for everyone.
Thanks, Julia. Bye. Bye, everyone. Thanks, Ty.
Yeah, thanks, Joni. Have a good day.